Welcome to our comprehensive review of infective endocarditis in pediatrics. I am Dr. Abdelaziz Yousef from Pediatric Case Review. In this presentation, we will explore the key aspects of infective endocarditis in pediatric patients, including epidemiology, risk factors, clinical presentation, diagnostic approaches, and management strategies. This condition, though relatively uncommon, carries significant morbidity and mortality in children, making it essential for pediatric clinicians to understand its nuances. Let's begin our journey through this important topic. Question 1. A 7-year-old with repaired ventricular septal defect presents with 4-day fever. Which organism most commonly causes pediatric infective endocarditis in high-income regions? The options are A. Streptococcus viridans, B. Enterococcus faecalis, C. Staphylococcus aureus, or D. Hacek group. Take a moment to consider the changing epidemiology of infective endocarditis in pediatric patients over recent decades, especially in children with congenital heart disease. The correct answer is C. Staphylococcus aureus, which accounts for approximately 28% of recent pediatric infective endocarditis cases, according to the Swiss SRPIE registry, from 2011 to 2020. We've seen a significant epidemiological shift over the past 2 decades, with Staphylococcus aureus replacing viridans streptococci as the most common pathogen. This shift is partly due to increased healthcare-associated line infections. Viridans streptococci now rank as the second most common causative organism, while infective endocarditis remains common in children with repaired congenital heart disease. The pattern of causative organisms continues to evolve, making Staphylococcus aureus the predominant pathogen in high-income regions. Question 2. A 5-year-old is being evaluated for risk of infective endocarditis. Which factor confers the highest relative risk for pediatric infective endocarditis? The options are A. Congenital heart disease, B. Central venous catheter, C. Rheumatic heart disease, or D. Poor dental hygiene. As you consider this question, think about the different types of congenital heart defects and their relative impact on endocardial vulnerability compared to other risk factors. The correct answer is A. Congenital heart disease, which carries the highest relative risk for pediatric infective endocarditis. According to population-based studies from the Danish registry, prosthetic valves or conduits increase the risk approximately 15 times compared to healthy children, making them the highest risk subgroup within congenital heart disease. Unrepaired cyanotic congenital heart defects carry about 10 times increased risk due to complex flow patterns and hypoxemia. Central venous catheters, particularly in the neonatal intensive care unit setting, increase the risk about 6 times. Rheumatic heart disease, which is decreasing in prevalence in high-income regions, still carries about 5 times increased risk. These data highlight why children with congenital heart disease require special attention for infective endocarditis prevention and prompt evaluation when suspicious symptoms arise. This slide illustrates the progressive formation of vegetations in infective endocarditis. The process begins with endothelial injury, typically caused by turbulent blood flow across congenital heart anomalies or prosthetic materials. This injured endothelium becomes the foundation for step 2, where platelets and fibrin deposit to form what we call non-bacterial thrombotic endocarditis, or NBTE. In step 3, transient bacteremia, which can occur during routine activities like dental procedures or even brushing teeth, allows circulating microbes to adhere to this platelet fibrin nidus. Finally, in step 4, bacteria proliferate within this protected environment, forming a mature vegetation where microbes establish colonies that evade host immune responses and antibiotics. Understanding this pathophysiology helps explain why certain anatomic and hemodynamic factors increase endocarditis risk. Question 3. An 8-year-old with tetralogy of Fallot-Repère presents with fever. Blood cultures are pending. Which statement about infective endocarditis pathogenesis is most accurate? The options are A. Vegetations typically form on the low-pressure side of cardiac defects. B. Bacteria directly invade intact endothelium. C. Bacteremia must be continuous for vegetation formation. Or D. Pre-existing endothelial damage promotes bacterial adherence. Consider the sequence of events in vegetation formation and which factors facilitate bacterial colonization in patients with congenital heart disease repair. The correct answer is D. Pre-existing endothelial damage promotes bacterial adherence. This is a fundamental concept in infective endocarditis pathogenesis. In repaired congenital heart defects like tetralogy of Fallot, abnormal flow patterns create turbulence that damages the endothelium. This damaged endothelium exposes extracellular matrix components that facilitate platelet adhesion and formation of non-bacterial thrombotic endocarditis. Option B is incorrect because bacteria rarely directly invade intact endothelium. They require this pre-existing damage. Option C is incorrect because even transient bacteremia, such as from dental procedures, can be sufficient to initiate infective endocarditis. Finally, option A is incorrect because vegetations typically form on high-pressure sides of defects where turbulent flow causes endothelial injury, not on the low-pressure sides. Question 4. A 12-year-old with bicuspid aortic valve presents with 2 weeks of low-grade fever, fatigue, and new heart murmur. Which additional finding would be most specific for infective endocarditis? The options are A. Microscopic hematuria, B. Osler nodes on fingertips, C. Elevated C-reactive protein, or D. Leukocytosis with left shift. As you consider this question, think about the classic peripheral and immunologic manifestations that help distinguish infective endocarditis from other febrile illnesses, especially which findings are relatively unique to this condition versus common in many infections. The correct answer is B. Osler nodes on fingertips. Osler nodes are painful, raised lesions on fingers or toes resulting from immune complex deposition and are highly specific for infective endocarditis. They're included as a minor criterion in the modified Duke criteria for diagnosis. The other options, while commonly seen in infective endocarditis, lack specificity. Microscopic hematuria occurs in infective endocarditis due to immune complex glomerulonephritis, but is also present in many other conditions. Elevated C-reactive protein is a non-specific inflammatory marker elevated in virtually all infections. Similarly, leukocytosis with left shift is common in most bacterial infections. It's worth noting that classic peripheral stigmata like Osler nodes, Janeway lesions, and Roth spots are actually less common in pediatric infective endocarditis than in adult cases, particularly in younger children. This slide illustrates the classic peripheral signs of infective endocarditis. Janeway lesions, shown on the left, are non-tender, erythematous macules typically found on the palms and soles. They result from septic emboli and are more commonly associated with Staphylococcus aureus infections. Janeway lesions represent embolic phenomena and indicate advanced disease with risk for systemic emboli. Osler nodes, shown on the right, are painful, raised nodules found on fingertips and toes. Unlike Janeway lesions, Osler nodes result from immune complex deposition and are included as a minor criterion in the Duke diagnostic framework. They represent immunologic phenomena and are highly specific for infective endocarditis. It's important to remember that these classic signs are seen in less than 5% of pediatric infective endocarditis cases, especially in younger children. Their absence should not exclude the diagnosis in a child with other suspicious findings. Question 5. A 6-year-old with tetralogy of Fallot repair has intermittent fever for 3 weeks. Blood cultures are pending. According to modified Duke criteria, which would establish a definite diagnosis of infective endocarditis? The options are A. 1 major plus 2 minor criteria, B. 2 major criteria, C. 3 minor criteria, or D. 4 minor criteria. As you consider this question, remember that the major criteria include positive blood cultures with specific organisms or pathogens and evidence of endocardial involvement on echocardiography. Minor criteria include fever above 38 degrees Celsius, predisposing heart condition, vascular phenomena, immunologic phenomena, and microbiological evidence that doesn't meet major criteria standards. The correct answer is B. 2 major criteria. According to the modified Duke criteria, a definite diagnosis of infective endocarditis requires either 2 major criteria or 1 major plus 3 minor criteria, or 5 minor criteria. The major criteria include blood cultures positive for infective endocarditis with typical organisms from 2 separate cultures, persistently positive cultures drawn more than 12 hours apart, or 3 or more separate positive cultures. The second major criterion is evidence of endocardial involvement on echocardiography, such as an oscillating mass, abscess, new partial dehiscence of prosthetic valve, or new valvular regurgitation. Minor criteria include fever above 38 degrees Celsius, predisposing factors such as congenital heart disease, vascular phenomena like emboli or Janeway lesions, immunologic phenomena like glomerulonephritis or Osler's nodes, and microbiological evidence not meeting major criteria. It's important to note that these criteria have limitations in pediatrics, with lower sensitivity in children with congenital heart disease and less common peripheral manifestations. Clinical judgment remains critical in suspected cases that don't fully meet these criteria. Question 6. A 10-year-old with a ventricular septal defect repair 2 years ago presents with 5 days of fever and fatigue. Which diagnostic test should be performed first in the evaluation for possible infective endocarditis? The options are A. Transthoracic echocardiogram, B. Blood cultures, 3 sets, C. Transesophageal echocardiogram, or D. Cardiac MRI. As you consider this question, think about the diagnostic priorities in this child with fever and repaired congenital heart disease. Which test will most directly impact immediate management and potentially fulfill a major Duke criterion? The correct answer is B. Blood cultures, 3 sets. Blood cultures should be the first diagnostic test in the evaluation for possible infective endocarditis for several critical reasons. First, they establish the microbiology by identifying the causative organism, which is crucial for targeted antimicrobial therapy. Second, blood cultures must be obtained before starting antimicrobial therapy to maximize diagnostic yield. Third, multiple sets increase sensitivity and help distinguish true pathogens from contaminants. Finally, positive blood cultures fulfill one major Duke criterion for diagnosis. For optimal results, proper blood culture technique is essential. Collect adequate volume, 1 to 3 milliliters for infants and 5 to 10 milliliters for older children. Draw sets 30 to 60 minutes apart. Use both aerobic and anaerobic bottles, and consider extended incubation up to 21 days for difficult organisms. Echocardiography is the cornerstone of imaging for infective endocarditis, with several key findings that clinicians should recognize. Vegetations appear as mobile, irregular masses attached to valves or the endocardium. Other important findings include abscesses, which are thickened areas with reduced echo density, new or worsening valve regurgitation, dehiscence of prosthetic material like patches or conduits, and fistulae forming abnormal communications between chambers or vessels. Vegetation characteristics can provide prognostic information. Those larger than 10 mm are associated with increased embolic risk, as are highly mobile vegetations. In children with congenital heart disease, vegetations are more common on right-sided structures. Transthoracic echocardiography, or TTE, is the first-line imaging modality with several advantages. It's non-invasive, provides excellent images in children due to better acoustic windows, and allows for serial monitoring. However, TTE has limitations, including lower sensitivity for small vegetations, limited utility for prosthetic valves, and potential to miss perivalvular extension. Transesophageal echocardiography, or TEE, offers higher resolution images and better evaluation of prosthetic valves and perivalvular complications, but it's invasive, requires sedation or anesthesia, and may not be available for smaller children. Question 7. A 9-year-old with confirmed infective endocarditis due to Staphylococcus aureus has been receiving appropriate antibiotics for 5 days. She develops sudden right-sided weakness and aphasia. What is the most likely complication? The options are A. Septic arthritis, B. Mycotic aneurysm, C. Embolic stroke, or D. Brain abscess. As you consider this question, think about the timing of symptom onset, the causative organism, and the specific neurological presentation. Also note that this patient has several risk factors for complications, including Staphylococcus aureus infection, which is particularly virulent. The correct answer is C, embolic stroke. Several features of this case point to embolic stroke as the most likely complication. First, the sudden onset of neurological symptoms is characteristic of embolic phenomena, which typically present abruptly. Second, the specific neurological deficits, right-sided weakness and aphasia, suggest involvement of the left middle cerebral artery territory, a common site for emboli. Third, Staphylococcus aureus infective endocarditis carries a particularly high risk of embolic complications compared to other pathogens. Finally, the timing is consistent with embolic stroke, which can occur even after appropriate antibiotics have been initiated, especially within the first 1 to 2 weeks of therapy. The other options are less likely. Septic arthritis would present with joint pain and swelling rather than neurological deficits. Mycotic aneurysms typically cause headache or subarachnoid hemorrhage and are usually a later complication. And brain abscess presents more indolently with headache, altered mental status, and seizures rather than sudden focal deficits. As shown in the chart, embolic events occur in approximately 28% of pediatric infective endocarditis cases, making them among the most common serious complications. Question 8. A 4-year-old with tetralogy of Fallot repair has infective endocarditis with methicillin-susceptible Staphylococcus aureus or MSSA on blood cultures. Which antibiotic regimen would be most appropriate for initial therapy? The options are A. Vancomycin monotherapy, B. Oxacillin plus gentamicin, C. Ceftriaxone plus rifampin, or D. Penicillin G plus gentamicin. As you consider this question, focus on the specific organism MSSA and its known susceptibility pattern. The correct answer is B. Oxacillin plus gentamicin. For methicillin-susceptible Staphylococcus aureus infective endocarditis, an anti-staphylococcal penicillin such as oxacillin or nafcillin is the first-line agent. These beta-lactams are superior to vancomycin for MSSA due to better tissue penetration and bactericidal activity. Adding gentamicin for the first 3 to 5 days may accelerate bacterial clearance through synergistic activity, so this practice has been increasingly questioned in recent guidelines. Total treatment duration for complicated Staphylococcus aureus infective endocarditis is typically 4 to 6 weeks. For pediatric dosing, oxacillin is given at 150 to 200 mg per kilogram per day intravenously, divided every 4 to 6 hours with a maximum of 12 grams per day. Gentamicin is dosed at 3 mg per kilogram per day intravenously, divided every 8 hours with appropriate monitoring. This table outlines the recommended antibiotic regimens for infective endocarditis based on the causative pathogen. For methicillin-susceptible Staphylococcus aureus or MSSA, the first-line therapy is oxacillin or nafcillin, potentially with gentamicin for the first 3 to 5 days, with treatment continuing for 6 weeks. For MRSA, vancomycin is the first-line agent, with rifampin sometimes added for prosthetic material involvement. For penicillin-susceptible viridans streptococci, options include penicillin G or ceftriaxone with or without gentamicin, typically for 4 weeks, though this can be shortened to 2 weeks in uncomplicated cases. Enterococcus faecalis is treated with ampicillin plus gentamicin for 6 weeks. The Hatschek group of organisms responds to ceftriaxone or ampicillin sulbactam for 4 weeks. Fungal endocarditis, caused by Candida or Aspergillus, requires combination therapy with amphotericin B plus flucytosine for at least 6 weeks, and nearly always requires surgical intervention. For culture-negative cases, broad empiric coverage with vancomycin, gentamicin, and ceftriaxone is often initiated, with subsequent adjustments guided by epidemiological factors. It's important to emphasize that all therapy should be guided by susceptibility testing and infectious disease consultation to optimize outcomes. Question 9. An 11-year-old with infective endocarditis due to Staphylococcus aureus has completed 10 days of appropriate antibiotics. Which finding is the strongest indication for surgical intervention? The options are A. Persistent fever after 7 days of appropriate antibiotics, B. Single embolic event to the spleen on day 3 of therapy. C. Mobile vegetation measuring 6 mm on the mitral valve. Or D. Severe valvular regurgitation with heart failure. The correct answer is D. Severe valvular regurgitation with heart failure. This represents a Class 1 indication for surgical intervention in infective endocarditis, the strongest level of recommendation. Heart failure due to valvular dysfunction, especially acute regurgitation, is a life-threatening emergency requiring prompt surgical intervention. Medical therapy alone is insufficient to address the hemodynamic compromise caused by severe regurgitation. The other options, while concerning, don't rise to the same level of urgency. Persistent fever after 7 days of appropriate antibiotics is concerning, but needs additional evaluation to rule out other causes such as drug fever or secondary infections. It's not an automatic surgical indication without other factors. A single embolic event to the spleen on day 3 of therapy, while serious, is relatively common early in the course of treatment and doesn't itself necessitate surgery. The management of infective endocarditis in pediatric patients requires a coordinated multidisciplinary team approach. At the center of this care model is the patient with infective endocarditis, surrounded by various specialists who contribute their expertise. Cardiology plays a crucial role in echocardiographic assessment and hemodynamic monitoring throughout the course of treatment. The infectious disease team manages antimicrobial therapy, selecting appropriate agents, monitoring drug levels, and addressing infection control measures. Cardiac surgery evaluates surgical indications, plans interventions when necessary, and performs valve repair or replacement procedures. Neurologists become essential when managing neurological complications like embolic strokes or mycotic aneurysms. Nutritionists provide high-calorie dietary support critical for healing and recovery, particularly important in prolonged hospitalizations. Dental specialists address oral hygiene, potential source control, and future prophylaxis guidelines. This multidisciplinary approach offers several benefits, including coordinated care, improved outcomes, reduced complications, comprehensive treatment planning, and enhanced family support. Regular team meetings to discuss complex cases ensure that all aspects of care are addressed in a holistic manner. Question 10. A 6-year-old has tetralogy of Fallot that was surgically repaired 1 year ago. She needs dental extraction. According to current guidelines, which is the most appropriate approach to infective endocarditis prophylaxis? The options are A. No prophylaxis needed as the repair was more than 6 months ago. B. Prophylaxis with amoxicillin 50 mg per kilogram 30 to 60 minutes before procedure. C. Prophylaxis only if residual ventricular septal defect is present. Or D. 5-day course of amoxicillin starting day before procedure. The correct answer is B. Prophylaxis with amoxicillin 50 mg per kilogram 30 to 60 minutes before procedure. According to the American Heart Association guidelines, patients with tetralogy of Fallot repair who have prosthetic material and residual defects require lifelong prophylaxis for high-risk dental procedures. Typical tetralogy of Fallot repair includes ventricular septal defect patch closure and right ventricular outflow tract reconstruction, almost always using prosthetic materials like patches or conduits that remain permanently. These patients fall into the high-risk category that requires prophylaxis even beyond 6 months post-repair, particularly when residual defects are present near the prosthetic material. The appropriate prophylactic regimen is a single dose of amoxicillin, 50 mg per kilogram, with a maximum of 2 grams, given 30 to 60 minutes before the procedure. Dental hygiene plays a crucial role in preventing infective endocarditis, particularly in children with congenital heart disease. Poor dental hygiene leads to gingival inflammation and increased risk of bacteremia during routine activities like brushing teeth or chewing food. Regular brushing, flossing, and dental visits significantly reduce this bacteremia risk. Interestingly, the cumulative risk from daily bacteremia during routine oral care may actually exceed the risk from occasional dental procedures, highlighting the importance of consistent dental hygiene. For high-risk children, guidelines recommend regular dental visits every 6 months, brushing at least twice daily with fluoride toothpaste, daily flossing with assistance for younger children, antimicrobial mouth rinse for older children and teens, prompt treatment of dental caries and infections, and parent education about dental hygiene importance. The prophylaxis decision tree helps clinicians determine when antibiotic prophylaxis is needed. For patients with high-risk cardiac conditions such as prosthetic valves or material, previous infective endocarditis, unrepaired cyanotic congenital heart disease, or repaired congenital heart disease with residual defects, prophylaxis is recommended for dental procedures involving gingival manipulation. For patients without high-risk conditions or for high-risk patients undergoing procedures without gingival manipulation, prophylaxis is not recommended. Question 11. Current guidelines have narrowed the indications for infective endocarditis prophylaxis compared to historical recommendations. What is the most compelling reason for this shift? The options are A. Reduced incidence of infective endocarditis in pediatric populations. B. Limited evidence that prophylaxis prevents infective endocarditis from procedures. C. High cost of antibiotics for prophylaxis. Or D. Development of more effective antibiotics. The correct answer is B. Limited evidence that prophylaxis prevents infective endocarditis from procedures. This represents the primary rationale behind narrowing prophylaxis recommendations. Despite decades of prophylaxis guidelines, several significant evidence limitations exist. There have been no randomized controlled trials demonstrating the efficacy of infective endocarditis prophylaxis. Case control studies show conflicting results regarding prophylaxis effectiveness. Epidemiologic data hasn't shown a decrease in infective endocarditis incidence despite widespread prophylaxis use. Risk-benefit analyses indicate an extremely high number needed to treat to prevent a single case. Additionally, the risk of fatal anaphylaxis, estimated at 1 in 50,000, potentially exceeds the benefit in many cases. An important consideration is the origin of bacteremia. Daily activities like brushing teeth, flossing, and chewing food cause transient bacteremia, with the cumulative risk from these routine activities likely higher than from occasional procedures. Most infective endocarditis cases are not temporally related to a procedure. As stated in the American Heart Association guidelines, infective endocarditis prophylaxis for dental procedures likely prevents an exceedingly small number of cases, if any. The other options are incorrect. Pediatric infective endocarditis incidence has actually increased in some studies. As we conclude our comprehensive review of infective endocarditis in pediatrics, let's summarize the key takeaways. We've observed a significant epidemiology shift with Staphylococcus aureus now predominating over Viridans streptococci. While congenital heart disease remains a key risk factor, healthcare-associated infections are increasingly common. For diagnosis, blood cultures before antibiotics remain the cornerstone, with echocardiography being essential. The modified Duke criteria are useful, but clinical judgment remains critical in pediatric cases. Treatment must be pathogen-specific, typically requiring 4 to 6 weeks of therapy. Surgical intervention is indicated for specific conditions, particularly hemodynamic compromise due to valve dysfunction. In terms of prevention, daily oral hygiene is more important than episodic prophylaxis. Current guidelines recommend targeted prophylaxis only for the highest-risk patients. A multidisciplinary team approach is essential for optimal outcomes. Thank you for joining us for this presentation from Pediatric Case Review. We encourage you to like and subscribe to our channel. Comment with any questions you might have and share this information with your colleagues. We look forward to bringing you more informative presentations on pediatric topics in the future.